Welcome to Talking Back to Suicide. This is your host, Dr. Diane Kaufman, although I prefer to be called Diana for my creative self. I'm a retired child psychiatrist as of June 2023. I'm a poet, artist, founder, director of the Hold On campaign for suicide prevention that uses the power of art to educate, connect, express, and heal. And I'm very happy to welcome our guest today, Dr. Gary Sprouse. He is a retired primary care physician who provided care for patients in Maryland for 38 years. He graduated from George Washington University Medical School in the top 10% of his class and is a member of Mensa, an organization open to people who score at the 98th percentile or higher on a standardized supervised IQ or other approved intelligence test. From his own life experiences of carrying a 55-gallon drum of stress for decades, Dr. Sprouse emerged to become the less stressed doc, vehemently declaring, "Don't resign yourself to being weighed down by stress, worry, guilt, or regret." He is dedicated to helping people improve their mental health, especially overcoming the weight of stress, burnout, worry, and/or addiction. Dr. Sprouse is the author of Highway to Your Happy Place, a roadmap to less stress, which received a gold medal from the Independent Publisher Book Awards and was a winner of the National Indie Excellence Book Awards in their well-being category. He contributed to Jack Canfield's best-selling book, Mindset Matters, Creating a New Narrative for Success, whereby true stories of growth, resilience, and triumph in the face of adversity are shared. He's also the host of the Happiness Highway podcast. So warm welcome, Gary, to Talking Back to Suicide. And we're so happy that you're with us today.
Well, Diana,
getting into our happy place.
There you go. Exactly. Well, Diana, thank you for having me on here. And I'm hoping that by the end of this episode, we're going to help at least one person. So.
Wonderful. So I was intrigued by your comment about a 55-gallon drum of stress. Could you say something about that?
Yeah. So, it's interesting as physicians, we tend to minimize the kind of stresses that we're under. But when you sit back and look at it, like every time a patient came to my office, every single one, I would give them some advice or give them a prescription or order a test or get them to a surgeon to get surgery. Any one of those decisions could have gone wrong and somebody would have either been gotten worse or possibly even died. And if something didn't go right, then I could have gotten sued for $1 million. So literally every decision you make as a doctor is $1 million decision and a life and death decision. But if you thought about that every time you made a decision, you would be overwhelmed by lunchtime. So we tend to minimize that stuff. But when you sit back, and it came to my realization when I was talking to an insurance agent over dinner, and we were talking about something, and I picked up the phone, and somebody was calling me from a nursing home, and somebody was having chest pain. And I said, I asked some questions and basically gave him some Maalox. And I hung up the phone and got back to the conversation. And the guy across the table from me was like, "Wait, did you just tell somebody that was having chest pain to take some Maalox? What if you were wrong?" I'm like, "Yeah, welcome to my world. This is what you do. We are trained to take care of patients, and you have to figure out, where the important information is, and then make a decision very quickly." And so that was just the beginning, right? That's just what you do for a regular job. But then you throw in things like insurance companies giving you a hassle, and being supervised by your board of physicians, and malpractice suits, and then family life. Oh yeah, right. You got, I had to go through a divorce, and my kids are growing up. So when you put all that together, that's a crazy amount of stress.
So before perhaps discovering, learning about, and also creating that highway to happiness, how did you manage your stress?
Well, so fortunately, the book that I've been writing, Highway to Your Happy highway to your happy place, a roadmap to less stress. So a lot of the ideas were already kind of rolling through my head as I went along. The thing that made me actually write, so the book ideas started like 25, 30 years ago. And then like about 5 years ago, I go, you know what, this book needs to get done. And I finally made the commitment and finally wrote the book down. But all the ideas had been running through my head as I was in practice. Started from the time when I was a resident. One of the things that I learned was a technique I use called the empathy wall. And what I realized is that I needed to have a wall around me that was thick enough that I wasn't going to fall apart every time somebody came with a disastrous story, because as a doctor, everybody's coming in with a disastrous story. So I had to be thick enough that I wasn't falling apart every day, but it had to be thin enough that I could still be empathetic with people and listen to their stories. And so that wall I found there were 2 stones that were in that wall. And I learned this very quickly. When I first started in practice, I was called a young whippersnapper doctor. I'm like, yeah, I'm going to come here. I'm going to fix everybody. And by the end of the day, I was overwhelmed. And it's like, oh, this isn't going to work. So one of the things that I had to learn early on is that as a doctor, I can't fix people. That the best that I can do is to give them the best advice that I can give them and get really good at giving the advice and persuading people to do the things I ask them to do. But my metric of success isn't did they get better. It's did I give the right information and did I give it in a way they could use it. If they got better, yay, that was really good. And then I could do that again for the next patient and use that experience to help the next patient. But then I could go home at the end of the day going, okay, I helped a lot of people. I gave them the right advice. I did it in a way they could hear it. And so I was successful today. The second stone was what I realized is that my stresses were a 10, but everybody else's were a 5. So I could do it, if I was having problems, I had to put all my energy into trying to solve those issues. But when other people came to me, they couldn't be a 10 like mine were. They had to be a 5. So that then I had enough room to take care of people, more than one person. So what I found was that my problems, and my effort to solve those problems would max out at a 10, but everybody else's problems had to be a 5, because you don't have enough effort, you don't have enough energy to give 10 to every single person, or else you'd be done by the end of the day. So I told this to one of my mothers who was taking care of her son. And she's like, I'm so stressed out. I don't have any energy. And I'm like, what's going on? She goes, my son is he's having all these problems and I don't know what to do. And I'm like, wait, step back. Like, those are his problems. Like, you can help him. I want you to help him, but his problems are a 5 to you, not a 10. And she took that information and she's like, oh my God. And she's like, you could see that the weight had been taken off her shoulders. So it's not that she stopped helping her son, but she stopped taking responsibility for his problems and became an assistant, not the primary person trying to solve the problem. So by doing those 2 things, you get this wall around you and you go from being overwhelmed to now you kind of feel better. You're like more in control of the situation.
Are there situations though, Gary, where let's say you're working on to help yourself, meaning you, that your stress is now at a 5 and you could handle someone whose difficulties were at a 10?
Yeah, absolutely. That's so here's what I've learned, right? So so when people come in and say they're really stressed out, and I say, I talk to them about what are their stresses. And here was the realization that brought me to writing the book. Was as a doctor, I'm used to writing a prescription that says, hey, here's a medicine for your blood pressure, your diabetes, and it works really great, but it might have some side effects. And when I stepped back and took that idea of something could be good, but have some side effects, and realized that our human skills are great. We have these amazing skills, but they have side effects. So we had the ability to envision the future, and you're like, wow, that's an amazing skill. We can plan, we can look into the future and figure out whether we need an umbrella today or not. The side effect is that we have to worry about it. Mm-hmm. So it's often given out as advice to say, well, just live for today. And you're like, well, that's a really nice thought. First off, it's impossible as a human because we spend way too much time in the future. But second off, that's our greatest skill. Why would I want to give up that skill? Because it has the side effect to worry. How about I give up the side effect and keep the skill? So I look at my 1-year-old grandson, and he doesn't have that skill of envisioning the future yet. So he doesn't sit at the dining room table going, Dad, how are we going to pay for college? Because it just doesn't come up, right? As a 1-year-old. So his life is very happy because he can't worry. It's like he does, because he doesn't have the skill of envisioning the future. So he literally can't worry. So he's real happy, but he's also very vulnerable. So he needs people who can look into the future to make sure he doesn't get in trouble. So the idea that's behind this book was, then let's look at the majority of where our stresses are coming from as humans. And what I found was the majority of our stresses are side effects to our skills. So this idea of worry is just because we can envision the future. The idea of feeling guilt is because we can determine right and wrong. The idea of regret is coming from because we can make choices. So now we can regret our choices. We have self-esteem, but we can have low self-esteem because we have this ability to decide. We have self-awareness that we even have self-esteem. And then we have this concept of good and bad. Well, now all of a sudden you can have low self-esteem. Like my dog does not have self-esteem issues, right? She's got this big scar on her back, doesn't bother her, right? She doesn't care. She doesn't have that kind of self-awareness. And then I also see people getting overwhelmed because they can handle more than one problem at a time. But now all of a sudden they can handle 10 problems at a time, and now they get overwhelmed. So when you start looking at our stresses as the side effects to our skills, then you start going, all right, well, if these are the side effects, then what do we do to get rid of them? And the second thing that I found was that when I looked at it that way, then I realized these are the ingredients that make things stressful. So when people say losing your spouse is the most stressful thing you can have, or losing your job is a really stressful thing, I'm like, but what makes it stressful? That's the key, right? So if a patient came to me and said, hey, my wife died last week, and I'm like, that's really horrible. But then you go, well, what makes it so stressful? And then you go, oh, because he's worried about what's going to happen, and he's feeling guilty that he didn't do something, and he's regretting some choices, and his self-esteem takes a hit, and he's getting bored because he doesn't have anybody to go to the movies with, and he's overwhelmed because there's so much stuff going on. So I'm looking at this patient going, well, I can't bring your wife back. And it's left this big hole in your life to the point where you can't function. But what I can do is the ingredients. I can take care of these components. I can do something to help with your worry and your guilt and your regret and your boredom and your low self-esteem and you're being overwhelmed. Those are things I can do something about, which can then make that hole that's in your life smaller. It won't make it go away, but it will make it smaller. And now you can be at a point where you can function again. And so by looking at it that way, then you can start saying to people, here's some tools that are specific for worry. Here's some tools that are specific for guilt or being overwhelmed, as opposed to what I read in most books now, go, well, meditate or exercise or, do yoga or whatever. And it's like, these are very good skills. I'm not saying they're not good things, but they're very generic. So they just kind of work in general. And what I'm proposing are tools that work specifically for these things.
Gary, could you give a definition of stress? What is stress? And what's the difference between stress and anxiety?
Yeah. Well, good that you say that, because I just came up with that idea. So, there's there's a whole bunch of different definitions of stress, but here's the one that I found is very general and very broad, right? So what I say is, it is the effort that we have to take to adapt our changing body to our changing environment. So that means, like, I'm not the same guy I was yesterday. My environment's not the same as it was yesterday. And I have to keep figuring out how to adapt to that. And that effort that it takes is where stress comes from. And so people ask me, is there such thing as good stress and bad stress? I'm like, no, not really. There's just stress. The good and bad part comes from us. Like, we put that on. That's where our mindset comes in. And how we perceive as stress is whether it becomes good or bad. So if you get nervous before you do a talk, I don't know, is that good or bad? So I was talking to a performer, and he tells me that he throws up every time he performs. And you're like, but you've been performing for 40 years. He goes, well, yeah. And you would think, doesn't it go away somewhere along the line? He's like, no, but it makes me a better musician. I'm guessing if he doesn't throw up, then he feels like something's not right, right? So our perceptions then decide whether something's good or bad in terms of stress. Anxiety, to me, is more of a fear reaction. So if I look at fear, that reaction can be from a mild anxiety all the way up to a panic attack, but it's all a fear-based response. And that is one of the main ingredients to worry. So when I started defining worry, because I don't know if you, but I've had patients come in and say, Dr. Sprouse, I worry too much. I'm like, well, then you probably do. But when I said to them, well, tell me what worry is. And they got this look in their face like, I got this. But then when they started trying to figure it out, they were like, it wasn't as easy as they thought. And so when I came up with a definition for worry, here's my definition. We have this incredible skill of envisioning the future. But then we focus on all the bad things that can happen. And then we have a fear reaction to those things that haven't happened yet. So they're really just concepts, but we're now having a fear reaction, which is tangible, right? I mean, your heart rate goes up, your blood pressure goes up. And so when you start having a fear reaction to things that haven't happened yet, well, all you have to do is think up something and all of a sudden you're having a fear reaction. And our bodies were designed to have a fear reaction to get away from some dangerous thing or to hide or whatever. But when you're having a fear reaction over and over and over, and I'm like continuously, and so waking up at 2 a.m, your body wasn't designed for that. And so I say to people, look, I can drive my car at 120 miles an hour for a little while, but then it starts breaking down. And our bodies are the same way. If we start having fear reactions all day, every day for years, your body's going to start breaking down physically because it can't handle that amount of effort that has to go into it. And so that's why I found that it was real important to help people with their stresses, because what I learned was, a lot of people go, oh man, I want to live the stress-free life. Like, I'm sure people have said this to you now that you're retired, right? Oh, your stress is so much less. And you're like, well, they're less, but they're not gone. Like, there's still stress is gone along, right? And so what I say to people is give up the romantic idea that you're going to get rid of stress. Because based on my definition, that doesn't happen until you're not alive anymore. Like, as long as you're alive, you're going to have stress. So stop wasting energy and time thinking you're going to get rid of stress. Stop feeling guilty that you haven't gotten rid of stress. And what I want you to do is start figuring out how to manage the stresses that you have in front of you. And one of the ways to do that is to recognize where they're coming from. And the majority of our stresses are just side effects to our skills. So then let's figure out a way to get rid of those side effects, and your stress will be a whole lot less.
I really love the reframe that you've done on having difficulties, that it's a side effect of your skills.
Yeah, right. Yeah, it works well.
And very clever to think of it that way.
That, right? And so then the next piece to this was, I've had patients come up to me and go, Dr. Sprouse, I know where I don't want to be, but I don't know where I do want to be. And you're like, well, that's a problem. And I see this in a lot of people. They don't know where they've only thought about having less stress, not this idea that they could be somewhere that's good. So when I would do a seminar, I would ask people, tell me where your happy place is. And then, somebody would raise their hand and say at the beach. And you're like, yeah, that's great. That's where I am. That's my happy place. I like being at the beach, right? My wife thinks the beach is a big kitty litter box. And you're like, well, this is a problem, right? So what I said, how often do you get to go to the beach? And they go like, I don't know, a couple weeks out of the year. I'm like, so that means you're not in your happy place 50 weeks out of the year. Well, that's not good, right? We want to be in a happy place all the time. So when I started researching out what makes up your happy place, what I realized is everybody's happy place is a little different, but they all have the same rooms. They just decorate them differently, right? So they all have a kitchen. They just decorate it with different equipment, or they have different colors. Everybody has a bathroom, everybody has a living room. And so everybody has the same rooms, and they just have different decorations in there. So when I started looking at the rooms, I'm going, okay, the rooms have gratitude and pleasure and anticipation of pleasure and having a feeling of fulfillment. And then I have this acronym I use called CASH, where it's like you feel connected and controlled, and you have acceptance and appreciation, you feel safe, and you have a spiritual sense, and you have humor, and you have hope. And then the last one is contentment, which is kind of a combination of all those other rooms. And what I found is when you understand that that's what makes up your happy place, you're like, dude, that's in my pocket. I can pull that out at any time. I can be in the middle of yelling at my kids for doing something stupid. And I go, oh, wait, let me pull out my happy place. Oh, I'm grateful that I have kids. And then I have hope that they're going to get better. So they're not going to do that dumb stuff again, right? So when you have a happy place that's in your pocket that you can pull out any time, and you have a way to get rid of some of the stresses that are keeping you from the happy place, then life gets way more fun.
It seems as a primary care physician, you've had a lot of experience with the mental health of the individuals that come in to see you. Were you surprised by that when you began your training? And another question is, as a primary care physician, was there medical school, internship, residency training on the mental health aspects of being a primary care physician?
So I think I understood pretty early on that mental health was playing a role in most people's physical condition. But as I wrote this book and did the research for it, I got better and better at figuring that part out. I will tell you one of the sobering statistics that I read as a primary care doctor is that if I said, hey, you're having some mental health issues, you need to go see a mental health professional, there was a 75% chance that they wouldn't go for whatever reason, money, insurance, stigma, whatever. What I learned was that patients were way more comfortable coming to me for mental health reasons. Because what they would say if somebody said to them, hey, where are you going? You're like, yeah, I'm going to go see my primary care doctor. They didn't say to them, oh yeah, because I'm worried, I'm depressed and I'm thinking about committing suicide. But if they said, their friends say, where are you going? You're like, yeah, I'm going to go see my psychiatrist. Like, oh, what's the matter with you? And it's like, so there was this sort of stigma that went along with it, which wasn't there when they went to their primary care doctor. So I had to make the decision, either send people to a mental health practitioner and realize that most of them aren't going to go, or start learning how to do some of this myself, which is where I took that route. So I've always felt that the mental health part was just as important. And it would be so difficult sometimes, because if I was in a room with a patient who was having chest pain and they're getting ready to have a heart attack, and I'm calling the ambulance, and now I'm an hour behind, right? Because this took a lot of time. And the people in the waiting room were fine because they're like, okay, well, there's an ambulance. Right. But if I was in the room with somebody who was thinking about committing suicide and I'm trying to save their life, when they walked out of the room, they didn't look sick. They didn't look bad. So then patients would be mad going, why'd you take so long with that patient? You're like, you don't understand. My job here was to save that person's life. Probably, and they were probably closer to death than the guy was having a heart attack. But if not more, at least the same, right? So it made it difficult because doing mental health stuff is a little more time consuming. So it makes it hard. So in my practice, I was my own boss. So I could decide, I could take more time. I didn't have the stress of my boss telling me you only get 15 minutes. And I'm like, what am I supposed to do? This person who comes to me and says, hey, I'm thinking about killing myself. I only got 10 minutes left. Like, what? That doesn't even make sense. And they're like, okay, I'm going to send you to this psychologist and psychiatrist, knowing that they might not go. And you're like, that would be bad.
Say a little bit more about mental health impacting physical health.
Wow. So there's a book that I read, and it's a great title. It's called Why Zebras Don't Get Ulcers. And the guy spent 300 pages telling you all the physical things that happen from stress. And what his point is that zebras will be eating grass and a lion will show up and they'll go, a lion, and then they run away. But then as soon as they can't smell the lion anymore, they go back to eating grass. But for humans, we go, oh, there's a lion, and you run away. But then you're hiding behind a bush going, oh, what if he finds me? What if he comes back? What if my kid? So then we don't ever stop having that fear reaction. And so what it does then, it literally affects every organ in your body. But the main ones, like I just had a lady the other day, she's 18 years old, and she was having belly pain. And we had to assess what's going on. And so what we realized was she had both things. She had a lot of stresses going on, but it had caused physical problems. So now she was having an ulcer, right? So people will get asthma and their asthma will get act up. They'll get headaches because now what's going on in your body is there's this increase in adrenaline, this increase in cortisol, and those things decrease your ability to fight infection. They increase the acid in your stomach. So all these things are related to the physical aspects that come from having a fear reaction over and over and over and over again, or whatever other physiological reactions that are triggered by your emotions. And so by changing the stresses and your emotional reactions, then you can actually change your physical. And I saw this in patients because I was in practice long enough where I'd see somebody who was having high blood pressure and I had to give them 1 or 2 medicines to get their blood pressure under control. And then they would retire. And all of a sudden they didn't need blood pressure medicine anymore. And you're like, whoa, that's a big deal, right? So it's like clearly there's a correlation there between what people are feeling in stress and their physical body. There's a term that I learned, like patients are pretty familiar with the term homeostasis, where you're trying to keep the temperature right around the, like a thermostat. But I learned this term called allostasis. And you're like, wait, what is that? So it turns out allostasis is the human body's ability to predict, the body is predicting what's going on. So if I'm working with my hands, with hand tools, then my hands start developing a callus because they go, oh, you've been working with hand tools and it's hurting our hands. And so we're going to develop a callus. So like tomorrow when you use a hand tool, you'll be more protected. And the same thing goes along with stress, where you go, hey, you had stress yesterday. You're probably going to have stress tomorrow. So we're going to jack up the cortisol level and the adrenaline level in the morning because we know we're going to have to deal with some stresses. So we're going to be prepared for that. And so with allostasis, then that stress, whether you have it or not, doesn't matter because your body's predicting that you're going to have it. So it's setting you up to be ready to handle the stresses. So it takes a little while to kind of let the allostasis. So if I stop working with my hands, eventually the calluses will go away and I'll go back to having baby hands, right? So it takes a little while once you've been dealing with so much stresses to then calm the body down and not have that allostasis where it's predicting that you're going to have stress tomorrow.
Did you ever have experiences, Gary, with any of your patients when you'd bring up mental health aspects that the person took offense to that?
You know what? Not really, right? Most people, they come to the doctor for physical reasons, but everybody has some mental issues going on. So I think as a doctor that my patients enjoyed that I would be willing to talk about those things because that was something that was really bothering them a lot. There are times when I felt like I was a priest listening to confession because people would say to me, like, I did this thing, like, somebody might have had an affair and got an infection or something. And they're like, they didn't want to tell anybody else, but they had to tell me because I needed to get an antibiotic or they just needed some help or whatever. And it's like, so there were times when I felt like people were confessing to me. And here's what I found. That really works. When you are feeling guilty about something or you're regretting something and you're holding it inside of you, it does stuff to you, but negatively. So when you find a person that you can talk to, that's empathetic and that's, what's the word I want to use? Is non-judgmental. That is this release. So now there's at least one other person in the world that I can tell this to and not get looked down on or beaten up for or whatever. That by being allowed to release that makes people feel so much better. So I found that people really enjoyed that I was willing to sit down and talk to them. And what I found was, it was an interesting thing. As I talked to people and they got more comfortable because they had shared something with me, two things happened. One, I was willing to share with them. So there were things I told people about my life. I'm like, look, if you're going to tell me about your life, I'm going to tell you about mine. And I felt like that dialogue allowed them to open up because if Sprouse is willing to say something to me, then I'm willing to say something to him. But two, by opening up, and it led to, oh, and by the way, I forgot to tell you that this hurt or that hurt, or I forgot this, or right. So there were other symptoms and signs that came up during the conversation that allowed me to make the right diagnosis instead of missing the diagnosis. And so I thought it made me a much better doctor to do that.
Communication is so important, right? To be able to listen. And yet I'm thinking how there's still a stigma around mental health, right? And what you mentioned earlier about, referring you to a psychologist or a psychiatrist. What can we do about that stigma?
Yeah. Well, two things. Well, I think the reason that it happens is because our mental abilities are what separate us from other animals. Like, my dog's there and cat's there. They got brains, they move around, they have emotions. So what separates us is these other things that I call the mind. And the mind skills are what separate us. So when those aren't working right, then we start, like, I see this. I took a lot of patients with dementia, and it's like, you've now lost that mind skills. And you're like, people look at them like they're not human anymore, in that they've lost that differentiation from what other animals. So now they're just like taking care. They just have the same skills, like that a monkey might have, right? I mean, they don't have the same skills that other humans have. So losing our mind is like worse than dying. Like most people say to me, if I get demented, just kill me. Like, I don't want to live like that, because they've seen other people in that situation. So it's really scary to people to be losing their mind skills. So then going to a psychologist, psychiatrist, two things. One, they either losing their mind skills, or they're weak and they can't handle it. And that makes them not want to go get help, right?
What can we do about that?
So
to break through that stigma?
Okay, so here's the model that I have for how our brain works, right? So there's this model I've been working on called stratospheres, which gives us a different lens to look at the world. And so I look at the world in terms of layered spheres. So when you do that, then you go, okay, here's a brain. So we have a brain, just like my 1-year-old has a brain, my demented patient has a brain. And if I do a CAT scan on them, they look pretty normal, right? But they don't have the same skills. So what's going on? So in my model, what I said is, okay, you have brains, so you have a certain amount of neurons and a certain amount of connections. But if you get the right amount of connections and the right number of connections, then you cross a threshold. And so these new traits show up, they emerge, right? So you get these emerging traits. And for us, it's things like self-awareness. It's things like having the ability to choose. It's having the ability to predict the future, envision the future, having language, using tools. These are all skills that are up at our mind level, knowing right from wrong, good and bad.
Problem solving.
So these are all things that are up in that mind level. But if you lose the connections through a stroke or a brain injury, now you start crashing. You go back through the threshold and you're back to just having a brain. So my patients with dementia have a brain. I mean, they walk around, they eat, but they don't feel bad that they're wearing plaids and stripes together, right? They don't feel regret that, they yelled at their son the other day, right? So because they've lost those skills. So when you start thinking that these skills are a part of the brain itself, then people will go, oh, well, that's just a different part of me. And I think the second thing was that money plays a big role in this, right? And I think part of the problem that we've gotten into is that our ability to help people with their psychiatric or psychological problems isn't as good as it should be. And so, like, I have a friend of mine who's basically been locked in her house. It's been like 10 years now, right? She has agoraphobia and panic attacks and all kinds of stuff. And she's seen psychiatrists and psychologists and taken medicines and done hypnosis and like all these different things. And she's still locked in her house. And you're like, that's 10 years of treatment and she's not a whole lot better. And you're like, yeah. So if we could say, hey, if you come here with depression, I'm going to fix you in a month, I think people would be way more likely to get involved with that therapy. Does that make sense? Am I saying that right?
If that woman were your patient, what would you be doing for her, or providing, listening, referring?
So her problem was that she had had a very traumatic childhood, horrible, right? And so after having read this, you probably read the book, The Body Keeps Score, right? What I learned in that book was that people store traumatic memories differently than they store regular memories. So a regular memory is done by our frontal lobe, and it says, hey, there was a beginning to the story, there was a middle to the story, there's an end to the story, and it happened in a certain time frame, and you lock it up, right? But when you have a traumatic memory, the thinking part of your brain gets turned off. So now what you get is a memory that's just a snippet of a smell or a sensation or a visual thing, and it's triggered off by whatever's in your environment that you don't even remember. But what comes along with those triggers is the emotion that went along at that time. So now you're watching TV and you see some father, smack their kid across the head. That's part of the TV show. And all of a sudden you're freaking out on the couch going, oh, and you're like, what? And there's person with them is going, what is the matter with you? What's going on? And they're going, I don't know. I'm just freaking out. Right. And so it's very distressing. And so they end up doing things like, I'm just going to stay in the house because I don't want anybody seeing that kind of reaction when I'm out going grocery shopping or wherever else. So their mechanism to try and fix that is to just stay in the house, or they do drugs to kind of get rid of all these, just sort of drowned everything out, or they just go numb and they just go, you know what, I'm not going to have any sensations and we won't worry about it, right? So these are all different mechanisms that people do to deal with their traumatic memories. But one of the skills that I learned was how to do neuro-linguistic programming, which is done under hypnosis. And what that does then, and this is my interpretation, is that it takes that traumatic memory and turns it into a more normal kind of memory with a story where there's a time frame to it, and it reframes the emotions that are attached to it. So you don't lose the memory, but you lose the emotions that were attached to it. So I'll give you an example. I had a lady who had gotten beat up when she was 40 and was having panic attacks a lot. Tried alcohol, went to the psychiatrist, took Xanax, did religion, did all these different things, and none of it was really helping very much. And I got to meet her like 20 years later, and she's still having all these problems. We did 1 hour of neuro-linguistic programming with hypnosis. And during that hour, what we learned was that when she had gotten beat up, the emotions that she remembered, like this, she remembers getting punched and laying on the floor and feeling a victim and feeling in pain and feeling out of control. But when we went through the hypnosis and she had more access to the memory, what we learned was that she had passed out. And when she woke up, the guy was beating somebody else up. And so she had a decision. So she decided to get up and help and call the police, and they came and everybody was okay. So when we got done the session, I looked at her and I said, so you're a hero. And she's like, what? And I'm like, well, you're a hero. I said, you risked your life to help somebody else. And you could see that her body language changed, right? So now that memory is still there. It's like if you said to her, hey, remember that time you got beat up? She goes, yeah, but that was like 20 years ago. Now the memory, instead of bringing up fear and pain and isolation and out of control, now brings up, I was a hero. And you're like, well, that's a way different reaction. So now she doesn't have a panic attack anymore because of that. But then it turned out that the reason that time when she got beat up set up was when she was 8. She came back 2 weeks later and said, Dr. Sprouse, we got to do another session. So when she was 8, her dad had been drunk and took a knife to her mother. And so there's blood everywhere. And again, she remembered being 8 years old and watching her mom get cut with a knife and blood everywhere. And she had this memory that she had cleaned it up and she was all alone and none of the neighbors helped out. But under hypnosis, she got access to more memories, and she found out that, oh, wait, no, one of the neighbors did come. And it turned out she was trying to protect her 4-year-old brother from seeing all this. And so the neighbors took them out of the house. They came back and cleaned her up, got them out to the hospital and everything. She healed up okay. But again, we did the same reframing. So I'm like, you're an 8-year-old girl watching the probably most horrible thing you've ever seen. And at that time, you're actually worried about your 4-year-old brother. What? That says something about you as a person, right? So again, the emotions that got attached to that memory got shifted to a more positive way to look at it. And so then she was much better at the end of that sessions. And so, yeah, I haven't really heard much from her since, because she went to her psychologist, and the psychologist like, what happened to you? You're like real different. And so she talked about what we did. And it's like, when I learned how to do this, the instructor was like, the title of the course was a brief intervention. And you're like, well, don't you run out of things to do if you fix everybody? And he's like, no, because what happened to this lady? They come back with, oh yeah, this happened and this happened and this happened. I need to work on that, right? So, and trust me, there's 330 million people that all could use this, because we've all had these traumatic memories that affected us in some way or other.
It seems that the interpretation of what happens in our life is so important. There's the what happened part of it, but then the understanding of the meaning that we put on it. Could you speak to that?
Yeah, well, so one of the things I talked about in the Traumatic Memories book was it made a big difference if you could get away. So like he talked about a lady who was being raped, and like I had a patient that somebody was trying to sexually abuse her, and she punched the guy in the nose and ran away. So what happens in that situation is your fear goes up because somebody's trying to attack you, but then you punch them in the nose and you run away. So then the fear action goes back down. But then the other person's getting raped and they're being held at gunpoint and their guy's holding them down. So their fear reaction's gone up, and up and up. And the fear reaction saying, run away or hide, do that right now. And the higher it goes, the more like, you run away. So as that builds up and you can't get away, that's where the problem starts. So the more that you've been restricted, you had no control. This is why childhood abuse is so bad. The two people that are supposed to be taking care of you and keeping you safe are the ones who are hurting you. What the heck are you supposed to do with that? And you're a little kid, so you can't get away because they're the ones that are giving you food and shelter. So you're stuck. So now you just got to get up every day in fear, and then you're having all these traumatic memories. And so, yeah, that gets you into trouble. So I had a lady who was drinking too much alcohol, and she got sober, great. And I was like, so what was going on in your life? And I said, were you abused by your parents? She goes, no, my parents are really nice. They were really nice parents. I said, what was going on? She goes, it was my sister. And I'm like, oh, so I've had to add this to my questions. Like we hear about parental abuse of kids, but siblings abuse their siblings a lot, right? And so it turned out that this lady's sister would literally beat her up every day. Every day she got up, her sister beat her up, and there wasn't anything she could do about it, or at least that's the way she felt about it. And so she had these traumatic memories of, being isolated and being like nothing she could do, helpless. And so then she just drank alcohol to try and alleviate those feelings. But then, and this is one of the things that I talk about, is I'm in the process of redefining addiction. Because right now, as doctors, we get trained that addiction is a disease, which, okay, so it differentiates from being a moral failure, but not really. So now what you're saying to somebody is, you have this disease, it's lifelong, so you're never going to get rid of it. The best you're going to do is struggle every day not to do it. Then it's probably because you're genetically defective, or you're weak-willed, or you're stupid, or you got a personality disorder or something that's led you to have this disease. And you're like, who the heck wants that? Like, I wouldn't want that, right? And so what then people do is they don't come and get help, because who wants to be labeled that? And they wait till things are so bad that they go, all right, fine, I'll take on the diagnosis, and yeah, all right. And then here's the problem, is then 20% of them get better and 80% go back and do it anyway. And you're like, there's something wrong with this picture. We got to do something different. And what I see is there's really smart people trying to help people with addictions. There's a lot of money in the system, and the people who want to get off are really motivated, and yet we're only getting a 20% success rate. And you're like, wait, something's wrong here. And to me, calling it a disease is where the problem is. So what I talk about is it's in the medical model, but instead of calling it the disease of alcoholism or the disease of opioid abuse, what I say is those things are stress reducers. And what they're trying to do, they are treatments that are trying to treat stress. So if you have stress and you haven't read my book, then you have to figure out some way to reduce your stress. And so we have all kinds of stress reducers. People ask me, like, Sprouse, what do you do to reduce your stress? And I go, oh, I watch TV, I read a book, I exercise, I do karaoke, I go out and kayak in my kayak, right? So there's all these different things that I do. But, oh, wait, sometimes I go out and have a beer, or and I've met people in my office and they're like, I'll smoke a cigarette, or I'll do heroin. And so what you see then is all these stress reducers reduce your stress. So I had patients that had been, abused as a child, and they were doing heroin. So when they did the heroin, they were like, oh, it feels so good. It feels warm. It feels like someone's hugging me with a soft pillow. And you're like, okay. But then then I wake up and I'm like, I had this hole in my arm and I don't even know what I put in there, and I overdosed and I had to go to the emergency room, and now I got this giant bill and blah, blah, blah. And it's like, so here's how I reframe it. So now instead of calling it addiction, I go, this is a stress reducer loop. So you have a stress reducer, but the stress reducer started causing stress, which then means you had to do your stress reducer more, which then caused more stress. So now you're in this loop. So I use the example of a guy who comes home from a dead day at work. So he's driving home from work and he stops off at the bar and he gets a couple drinks because he's had such a bad day. This is a stress reducer. And he feels better. So he gets in his car and he's driving home and he gets pulled over, and now he gets a DUI. So the stress reducer of alcohol, which was working, just caused more stress because now he's getting a DUI. So he goes home to his wife and he goes, honey, you won't believe this. I had a horrible day at work. I stopped off. I got a couple drinks and then I got a DUI. Ah! And she's looking like, that's insane. Why would he goes, wait, I can't talk about this. I'm going to go get a beer. And she's like, you can't get a beer. That's just what's caused the problem. He goes, honey, this is stressful. I got to drink some alcohol because that's what makes you feel better. So now his wife's getting him a hard time, right? So now the stress reducer is causing stress. So here's the difference in that model. So instead of looking at the person saying you're broken, you're diseased, you're something wrong with you, what this model says is you're normal. And I had patients with heroin, they're using heroin, tell me, wait, no one's ever said I was normal. I'm like, no, you're normal. You had stress like everybody else. You found something that worked. And then your brain made it into a track. It made it into a habit. So that because it's normal, all that is normal. Then you said, you know what? This heroin stuff is causing problems. I need to get some help. But then you got stuck because now you got this track in your brain. And humans have the ability to inhibit. We can say, no, I'm not going to do heroin. No, I'm not going to eat that chocolate donut because I'm on a diet, whatever. So we can do it. It's one of the unique skills that humans have. Other animals don't do that. But we're not real good at it. So if I'm trying to lose weight and I go to a gala and they have these beautiful desserts, like I might walk past them once or twice or 5 times or 10 times, but the 11th time I'm eating one of those tarts, right? And it's like, so we have the ability, but we're not that great at it. So when I see a patient that comes in and says, I'm trying to get off, they get sober, things are going great, they've been sober for 6 months, and then they come back and they've used. And I'm like, what? So in the disease model, the question that gets asked to me, why were you so stupid? Why did you give into your disease? What the heck's the matter with you? Like, you're going to get punished now because you messed up. And we're going to take away all the credit you have for being sober for 6 months and say, you're back to being an addict. In my model, what I say to them is like, so you've been inhibiting this for 6 months. You have this track in your brain that we can't make go away, but you just have to say no. And you did for 6 months. So what changed that you stopped being able to do that? And inevitably something stressful happened. As an example, one of my patients who, because of her addiction, wasn't allowed to see her kids, had gone to a park, and across the park were her kids, which she could now not go talk to or see, which freaked her out, which then she said, oh, I got to go use, right? So what that does then, it says to him, we're going to give you credit for the 6 months. You were really good for 6 months. And then you went down that track again, and we know now why. So now what we're going to use is as a learning experience and go, okay, we're going to figure out a way to put a little wall around that experience of when you see your kids and you can't go see them, so that the next time that comes up, you got a different alternative to use instead of going back and using whatever drug you were using. The other thing that this model does is does 2 things. One, what it says is that anything that anybody does to reduce their stress can turn into a loop. So one of my patients who was using heroin was telling me that his sister had a shopping loop. I'm like, okay, what is that? She goes, well, when she's upset, she goes shopping. But now her closets are full, her credit card's maxed out, and her husband's yelling at her, which upsets her, which she then goes shopping. And you're like, yes, that's exactly. So anything can become a stress reducer loop. And here's the other thing, is that anybody, if you give them enough stress, will end up in a stress reducer loop. And we saw this in Vietnam. Like 90% of the military people in Vietnam were using something. And the military was freaking out about it because they're like, when all these people come back, we don't have the resources to take care of all these people with all these different addictions. But when they came back, they just stopped. They didn't need it anymore because their stress levels went from 100 to 10. Well, they could handle a 10. They didn't need heroin or marijuana or whatever it is, alcohol, whatever it is they were using. They stopped. So that's so what that does then is it takes away some of the stigma from people who are using, which inhibits them from going back to get help, because it says, well, like I went to a methadone clinic to see what it was like. And what I realized was, the counselors were saying, these people with heroin abuse, they need to get their lives in order, and they don't want to get help, and blah, blah, blah. And I'm looking at them like, well, but you're 100 pounds overweight and you're a smoker. So you have your own stress reducer loop. It's like, you can't be throwing stones at them when you're having your own problems. Like, why don't you work on your diet? Why don't you stop smoking and then go back to them and say, okay, I did this and now I'm going to help you get rid of yours, because now we're in the same place. We're not like, I'm not up here and you're down here and you got to do everything I say or else. No, now we're in the same place. And so it makes a way different kind of therapeutic experience for the patients, number one, and for the person who's doing it too. So when patients would come to me and say, well, you never smoked, how do you know what it's like? I go, no, but I've been on diets trying to not eat chocolate donuts. And when I'm tired, my car just automatically drives into the local store and I'm buying a chocolate donut. Like, I'm like, where'd this donut come from? And it's like, yeah. So it's the same process, different things, right? You picked a different stress reducer than I did, but it's the same process. So I can understand exactly what you're going through.
Sarah, you mentioned a bit ago veterans, right, or those that have been in the military, and yet there is a high rate of suicide for
Absolutely.
those in the military. Could you speak to that?
Absolutely. So, okay, I was listening to a lecture on suicide the other day, and the statistics, and I don't even know if people understand these statistics, right? They hear about 50,000 people commit suicide every year, which is bad. But what they don't realize is 1.5 million try and 9 million make a plan to think about it, right? In what I say, I think every person in the world, it's crossed their mind, particularly if they're under a lot of stress. The more stress you're under, the more somewhere along the line you go, hey, if I just killed myself, this would all go away, right? Now, they don't think about it for very long. Maybe just goes through their head. But it's what I call it's a stress reducer. When you have stress, killing yourself makes all your stress go away. But when I would talk to my patients, I go, look, it makes all your stress go away. But I know you, right? Because I'm a primary care doctor. And I know you're not a selfish person. So it makes your stress go away, but it makes everybody else's stress around you 100 times worse. And for generations. Because what I've seen is, oh, well, my grandfather committed suicide, which then makes it more acceptable for me to do that, right? And so, and when people hear that, they go, oh yeah, no, I don't want to teach my kids that it's okay to commit suicide, because that's what you're doing if you do it, because now you're giving them the physical okay, I did it, so it's okay for you to do it, right? So what I find then is when the more stress that you have, and what I see with military people is a lot of them come back with these traumatic memories of. So one of the people that I met was he had served in Vietnam, and he was in a position where the enemy was about to overrun them. And so he didn't want them to get through them to more vulnerable places behind them. So he called in an airstrike to bomb where he was, because he knew the enemy was going to be on top of him. And so he knew when he called in the airstrike that he was going to die and all the rest of his unit was going to die. So the bombs came, they blew up. All the other people in his unit died, and he did not. So now he comes back to the United States, and he is just filled with survivor's guilt that everybody else died and he didn't. And so he wanted to go down and pay tribute to them at the Vietnam Memorial. But every time he even thought about going down there, he was freaking out. And so people then have a decision. So they can drink themselves, they can just numb themselves up, they can do drugs, or they can kill themselves because they go, I don't know what to do with this feeling. It won't go away. It's overwhelming me. If I just kill myself, it'll go away. Now, fortunately, he didn't. He was another person that I met when we were doing our classes in neurolinguistic programming. And so the instructor did a half an hour with him. And when he would say, let's go to the Vietnam Memorial, and you would watch him go, yeah, no, right? And then a half an hour later, he goes, hey, let's go down to the memorial. And he's like, yeah, let's go. And you're like, wait, that was a half an hour later. It's amazing to see the change that came from that. But the real key was he was sort of reframing what happened there to where his brain would then allow him to have that memory without freaking out. And what I see with people where they get further along in their suicidal ideations from just like, oh yeah, if it just wasn't here, it wouldn't be a problem, where they start actually making plans, is they go from my life sucks, because most people think their life sucks in some way, right? But when they add my life sucks and it's never going to get better, that's where the problem comes in. So we saw that in Viktor Frankl's book about the Holocaust. So he got through the Holocaust with the hope that he was going to get out and write a book and help a lot of people. His friend, who was surviving, had this hope that the Allies were going to come and free them March 1st. So when March 1st came and the Allies didn't, he was dead like 3 days later because he had lost hope. And so what I see with people that are thinking about suicide or actually trying it or whatever is that they've lost hope. They don't have hope anymore. So they go, my life sucks and it's never going to get better. And if you think that, then what would be the point of staying here? Like, suicide makes sense in that if you think that. What I see then is then they add that third line, which is, well, I'm just a burden to everybody. So now not only have they lost hope, but now they're a burden to everybody around them. And that's the one I send to the hospital going, no, you need to go to the hospital because this is bad. But what I found when I see people that are in suicidal ideation, I go, tell me what makes you think your life sucks. And tell me what makes you think that it's never going to get better. And I'll use an example of a lady I met. She was 16 years old. She had got admitted to the hospital. I never met her before. I just got her because I was on the rotation. And as I'm walking in to see this patient, the psychiatrist is walking out going, don't waste your time. She's a lost cause. There's nothing you can do for her. I'm like, whoa, that's a big statement, right? So I go and see the 16-year-old and I go, so what's going on? And to me, yeah, you know what? She's probably 18. Let's make her 18 because that'll make the story easier.
This was a medical unit that she was
on? She got admitted to a medical unit because whatever she had done to try to commit suicide got her to a medical unit. So I go in and see her. She's like, my life sucks and it's never going to get better. And I'm like, okay, so tell me why your life sucks. And so she's like, well, I work, but all my money goes to my mom who uses it for drugs. And I have to live with my dad, who's an asshole. And I have a boyfriend, but he's a pain in the butt. And I can't get my GED because I just can't do the classes. And I'm like, okay, well, so then let's revisit that. I go, so let me get this straight. So you've been working for 2 years for free. And she's like, what? And I'm like, yeah, you've been working for free because all your money's gone to somebody else. So that tells me you have this incredible work ethic that you're willing to do a job for 2 years and actually not get paid for it. I said, and we can change this because we can just say to your mom, guess what? We're not giving you any money anymore. So, go get your money somewhere else. I said, and you're living with your father, but you're living in a house, right? And she's like, well, yeah. And I go, well, isn't that nice that you're living in some shelter? And she's like, oh, yeah. Because at one point in my life, I was living out on the street. That was worse. And I go, got it. I said, and you have a boyfriend? I go, would you guys have sex? And she's like, well, yeah. It's like, do you like? She's, yeah. I go, okay, well, so he might be a jerk, but, he's got some good redeeming qualities. And I go, what's going on with his GED? And she goes, well, I don't know. I just get frustrated and I can't sit still. And I'm like, well, you probably have some ADD. So if we just gave you a little bit of medicine or some training, you'd be able to sit down, get your GED, get a better job, not have to live with your dad, find a different one, right? So literally like a half an hour later, she was like, okay, I'm ready to go home. Because now we had taken away that idea that her life sucked because it didn't suck as bad as she was thinking. And we gave her hope that there were things that were in her direct control that she could change. So then why would you want to kill yourself? It wouldn't make any sense.
That aspect of hope, right? And that there is something that I'm able to do to help myself.
Yep. Hope
and part of that also is reaching out for help to others.
I know, but that's where they get into trouble because they think they're just being a burden. So they don't want to help. They don't want to reach out. And here's what people say. So I have this concept that I give people called a perspective prism. And so in our prism is our facts and our theories and our experiences and our mindset, are we a growth mindset or a fixed mindset? Are we a victim or a creator? So all that stuff is in our prism. So when information comes in, it filters through that prism and it comes out as our perception. And it's our perception that then drives our emotions and our actions. So if you're in your prism, it says, my life sucks. And then it says, and it's never going to get better. Well, then it makes all the sense. If your perception is like, it's just not going to happen. Well, then that your emotion will be like, well, this is depressing. Why am I even here? Which then leads to the action like, well, I'm just going to kill myself because what's the point, right? So if I can't change her perception, what I can change is what's in her prism. And that's what we did. So when she said, my mom is a pain and my dad's this and we changed what was in here, which then automatically changed her perception. So she went from, hey, my life sucks, to like, my life doesn't suck that bad, right? Like, it could be bad, and I could do things about it, which then changed her perception, which then changed her emotions, and then changed her actions. So really what we have to do is find out what's in people's prisms and then try to figure that, fix that. So like, I had a lady who was 5 years old, and she was taking a bath, which was her safe place at the time. And her dad came home drunk, and he came up to the bathroom, grabbed her out of the bathtub and smacked her on the ass, and he made her cry, blah, blah, blah. And like, that was a traumatic memory to her.
And that's child abuse, by the way.
Yeah, right. Okay.
Mm-hmm.
I go, so you're 35-year-old now, right? I go, what would your perception of that be now? Like, say you're in the bathtub and your father comes in, like, now as a 35-year-old, like, get your drunk ass out of here. What the hell's the matter with you? Stop. Blah, right. So what we had to do is then say, she kept having that 5-year-old experience in there. We had to change it to, now she's a 35-year-old. How would she handle it as a 35-year-old? Oh, way different, right? So now then her perceptions changed that. So now it wasn't nearly as a traumatic memory, because now she's 35 and her reaction would have been totally different.
Interesting, that word prism, because I was thinking, oh, is your prism like a prison?
No. That's an interesting thought, right? So here's what I find. So like, as a psychiatrist, you'll appreciate this. So when I say to people, I give them this idea of a prism, here's what I say. So self-awareness becomes what's in my prism. Like, and what happens is most people don't even know what's in their own prism. Like, if you believe in God, like, how'd that get there? Most people would not have any clue. Like, they just, I don't know, just do, right? Why is your self-esteem bad? I don't know. Because self-esteem gets, I'm sure you know this, gets formed. By the time you're 5, you already have a lot of self-esteem, good or bad. And it's stuff that you don't even remember. Like, all that stuff was contributing to your idea of whether you had good self-esteem or not. But it was all stuff that happened where you don't even remember about it now. So now it just becomes a self-fulfilling prophecy because you don't even know what's there. So one of the things that I'm sure you did as a psychiatrist, and I know I was doing, was helping people go back and go, well, how'd that get there? And when you understand how it got there, like this lady, like, the reason it got there was because she was a 5-year-old and she was vulnerable, but now she's a 35-year-old, so she's not. So like, we don't need that anymore, right? Let's get rid of that one. And so when you understand what's in your prism, then you can be a better person, because now you know why you're remoting to these things. Now you know why you're reacting these ways, right? And the other end of that is then empathy becomes finding out what's in other people's prisms. So if I know what's in my wife's prism, then I'll be more empathetic. So we were taking a ballroom dance class, right? This is something that she really wanted to do. And we're taking this class, and she's starting to cry. And I'm like, what's going on here, right? And I'm trying to be empathetic. I have no clue what's happening here, right? I don't know why my wife, she's like, oh, I'm so stupid. I'm never going to be able to do this, blah, blah, blah. I'm like, you're a really good dancer. What the heck is going on here? Then she relayed the story. One of her experiences that was in her prism was that when she was a kid, she had taken a dance class and the instructor had shamed her. And she held on to that. And so now we're in a dance class and it was bringing it all back up again. And now, like, so now that I had the empathy of understanding that, now I could be a better husband because I know why this was going on, right? And so what I see then is our mental health world should be figuring out how do people get self-awareness and learning what's in other people's prisms, so that most of the problems will go away if you just figure those two things out.
Gary, could you speak a bit about burnout versus depression?
Wow. So interesting that you said that, because I'm going to get ready to do a talk for the director of nurses in Dallas in June. Okay. And the topic is burnout. So I've just been doing a bunch of research on this. So it turns out the one lady read a review article in the New England Journal of Medicine. She goes, I reviewed 182 studies on what to do about burnout. And she goes, out of the 182 studies, there was 142 definitions of burnout. And you're like, okay, that's a problem, because we were having a hard time figuring out how to define what the heck burnout is, right? What she came to the conclusion was there's a lot of overlap in the symptoms of depression and burnout. It's the depression we have a much better handle of based on what she said. And so she felt like we can treat them similarly. They're not that much different. There's some differences, but not that much. And so treating them as if they're the same thing is okay, because they have a lot of the same symptoms and a lot of the treatments are the same. But what I got out of my research was that this is what I decided. This is how I describe burnout, which is you want to do a really good job, but the system that you're working in isn't allowing you to do that. So like, I'll give you an example. So I had a teacher that was in my practice, and she had one teacher of our county, so because she was so good. But because she was so good, she had these really high standards that she wanted her kids to do really well, blah, blah, right? So the principal said, oh, look, you're such a good teacher. I'm going to give you a couple of my problem students. And then she did go with them. So he gave her a couple more, and then gave her a couple more. And all of a sudden she had a classroom of problem kids. But she had the same standard that she wanted to achieve, which was not achievable, right? So the two things happened was she didn't get more help to keep her standard up, and she wasn't willing to change her standard. So that led her to being burnt out, and then she quit. And I'm like, what? You're not any good of a teacher if you quit. Like what? Because what we had talked about was like, you're 100. Like if you're 95 is probably better than most people's 100. So we just need to tweak it down like 5 and you'll be okay. Or we got to go to your principal and get you more help and you'll be okay. But nope, what she ended up doing was burning out and just quitting. And you're like, right? So it's a big problem. And because what I've seen, that was 20 years ago. And what I've been seeing, and particularly in the medical field, is worse and worse and worse and worse. And it's interesting. I did a podcast guest we were talking about caregiver burnout, right? And what I'm realizing is that all healthcare professionals are caretakers at some level. And so we tell other caretakers, you should take care of yourself first, because then you can't take care of the other person. But we don't do it to ourselves. So we don't take care of ourselves first. It's like we're good at giving out the advice, but not good at taking it. And so what I found was there's really 2 solutions to burnout. The first is systemic. So you got to look at the processes that you're gone through to figure out what's there that we can eliminate. What can we make more efficient? What can we make as a group together, right? How can we help? But the other end is what can we do as the individual? And it's not just an individual problem, right? You can't just fix it by say, it's not the individual's weak or they're dumb or they just can't handle it. There's really specific things that they have to do to be able to handle more stuff. There's some attitudinal things, some things that they can change in their prism that would change their viewpoint of what's going on. So one of the things that I talk about is this idea, 2 things. So systemically, one of the things that we can do, and I wrote a song about this once, and what it said was, as caretakers, a lot of times we don't get appreciation. In fact, we'll get yelled at, right? You didn't do something right. We're going to sue you. We're going to turn you in your board, whatever, right? So you're actually getting punished for trying to be a nice person. But we don't get enough appreciation. And appreciation was, that's what I say, appreciation was the original currency. Before there was money, we had appreciation. You're like, oh man, thank you for those extra berries. Here's some extra fish, right? So we appreciated each other. So it's innate in us that we want appreciation. We might not say it out loud, but we want people to say, thank you so much for helping us. Like that's one of the things we're looking for. And we're not getting it in the healthcare field. We're getting the opposite. We're getting like, oh, I looked up in the internet what you said was wrong, or I'm going to sue you, or I'm going to turn you into your board, or I'm going to call your boss and say you did a crappy job, right? So we're worried about our 5-star reviews or whatever. So one of the things that I learned was if I'm working at a nursing home, we can give each other appreciation. Like I can say, oh, Diana, thank you so much for seeing that patient. That was so nice of you. And you can go, well, thanks for inviting me to come see the patient, right? So we can give ourselves appreciation. It'll fill up our tanks. And it's free. Like it doesn't even cost anything. We just have to do it, right? So like if we can set up a system where appreciation becomes something that we do normally, man, everybody will feel better. That's a systemic thing that we can all do. A personal thing we can do, and I talk about in the Happy Place where we talk about control. And one of the things that I see is you're never going to have 100% control, right? So give up that idea. But we do have more control than we think. And what happens is people give up their control because here's what they do. There are 2 ways they do it. One is they give up their choice. They go, well, I had to, or I must, or I should. And I'm like, no, you had a choice. You could have not gone. You could have said no, right? And it's like when you start, but if you said yes, like, so my friend is getting ready to start her business and she's starting next to her daughter and they have some conflicts every once in a while. I'm like, okay, you're doing this by choice. You don't have to be there next to her. You don't have to do this. You're doing this by choice. And when you do it by choice, then there's some more responsibility, because now you're going, okay, I did this by choice. So it was in my control, right? So when I was during the pandemic, I was going to the nursing homes despite the fact that I could die from getting COVID, right? But I was doing it because it was my choice. I could have said, I have to, and I must, and I should, and then I'd be miserable because I didn't feel like I was in control. But I was gone every day going, you know what? I'm deciding today I'm coming here because I want to take care of my patients. This is what I think I should do, and it's my choice. So it made me feel like it's control. The second way we give up control is by our emotions. And we say, oh, he made me so mad. And you're like, oh, stop that. Like, he did something, I'll give you that. But you decided to react with your emotion of anger. You could have decided to react any number of different ways. You made that decision. So now you need to take responsibility for your actions and your reactions, right? And your emotion. And when you do that, then you go, oh, so this is my friend. She's like, you know what? I was really upset at my daughter because she was being mean to me. And you know what? I decided that instead of me yelling, screaming at her, I was going to do something else. I'm like, yes. Because when you start taking responsibility, again, you feel like you're back in control of yourself, because now you're not just flying off the handle, reacting to whatever people do to you. Now you're making that choice. And I tell people, you need to be an actress or an actor. And they're like, what? And I'm like, I watched this TV show, and this lady went through 4 distinct emotions in 2 minutes without using a single word. And you're like, whoa, that was an amazing skill, right? I'm like, you don't have to be that good. You just have to be like a quarter that good, and you'll be okay, right? So it's like, we don't need to be like, you know, Emmy award-winning actor. We just have to be able to say, I have emotions, and I'm going to learn how to control my emotions and use them when I want to use them, not when other people are making me.
Gary, if someone's listening to us right now and is in extreme emotional distress, thinking, you know, and there's that word distress, stress, right? That the only way out is I want to kill myself. What would you say to them?
Okay. So the first thing I would say is, tell me what's going on in your life. What stresses are you feeling? And I go, what's happened to you in the past? What stresses are you having in the present? And what things are you worried about in the future, right? So I want people to be able to live in all 3 tenses. And once I made this assessment of where their stresses were coming from, then I would start working on their prism and go, so tell me why your life sucks, and does it really suck? Can we change that perception? And then tell me why you think it's never going to get better, and can we change that? And as I work through that, then people, their automatic reaction is they feel better, because now they go, well, my life doesn't suck that much, and I can do things to make it better. So why would I want to kill myself? And when I add in, and that would be a really selfish thing to do, they go like, well, I don't want to be selfish. And you're right. Let's figure out all the ways to deal with this. So then I would say, let's look at the stresses that you're having, what you're worried about, what you feel guilty about, blah, blah, blah. And then here's some specific tools to do that. But the first thing I say to people is ask for help. Don't sit there in your living room resigning yourself to this is the way it has to be. No, because that's the first step to getting better or getting help, is to say, I'm in trouble, help me. And what people do is they just sit there and go, oh, I'm in this cave, it's pitch black, and I don't know how to get out of here. So I don't like it, and I'm miserable, but I'm just going to sit here. And so my first thing I say to people is, don't sit in your dark cave. Get out and ask for help, because there's people like Diana. There's people like me. There's books out there. There's all kinds of things out there. There's neurolinguistic programming. There's lots of ways to make the situation better. But the first thing you have to do is get out of your cave and be willing to do things differently. And what my instructor said to me, look, whatever you're doing right now, you're getting an outcome. And you might not like the outcome, but the only way to get a new outcome is to change what you're doing on the input side. And the only way to change the input is to do things differently. And that's where we come in and go, look, we're going to help you do things differently so you can get an outcome that fits more with what you want to be.
And of course, there's the 988 number, right?
Yeah,
24/7, right? That you can talk to someone. You don't have to be at acute suicidal risk. You can be having a crisis of some type, and they're available to listen and to advise and to refer too. So Gary, how can we purchase your book, and what's your website?
All right. So the book is on Amazon or it's on Barnes and Noble. So you can just go on there, and it's in a paperback or a hardback. But we also did the audio book. It's also
Yeah,
an
I've been
ebook.
listening to your audiobook. Yeah, very
Yeah.
good.
Well, I tell people I'd gone to the Shakespearean show, and the guy who was lead character had this incredible, resonant, deep voice. I'm like, I want that guy to read my book. But then I learned that people want to know me, who I am. And so then it was like, no, you should read your own book. So that's what I did. My website is called thelesstressdoc.com. And on that website, I have access to a chapter from the book that's for free. So don't worry. So you can just download it. And then the other thing that's on the website is some of the podcasts and stuff that I've done. And then also is a course that I've given, that's online that you can take the course where it basically goes through the book, but in like little 15-minute segments of me teaching you what's in the book. So all that's on the website. And I'm just getting ready to start a program called Loop Breakers. And what I want to do is talk to people who are in loops and saying, hey, look, I'm looking, here's the target audience. It's people who have had a problem. They're in a stress reducer loop and they want to do something about it. And whatever they've tried in the past didn't work. So if you've gone to AA and that worked for you, go to AA. Well, I'm not here to bash AA, right? I want the other 80% of people who haven't gotten better and who need help or who haven't even asked for help. That was one of my sobering statistics. Like, we get a 20% success rate, but only 20% of people are actually even coming to us to get help. So it's actually way worse than we're thinking, right? So that's the people that I want to say. And what I tell them is like, look, loops come in 3 different fashions. There can be chemical loops like alcohol and cocaine and heroin, but there can be behavioral loops like gambling or sex or eating, or there can be psychological coping skills loops like we call it codependent, but I like to use the word self-sacrificing loop, right? So you can be in a loop from any one of these things, but come here and I'm going to help you get out. And what we're going to do is teach you what's going on and what you can do to get better, because that's going to be efficient. Like, I don't want to have you come and like listen to stories of other people and somehow you're going to gain some insight. And no, I'm going to teach you, here's the things you need to know, and then you can get out of it. And what we're going to use is the skills that you have as a human and try to minimize the weaknesses that you have as a human. And I think that will be way more successful. And in my office, I was taking care of 100 patients who had a heroin, opioid use disorder. And I was getting a 95% success rate. And it's like, yeah, because people wanted to come because I was treating them like they were normal. And so they liked that. And I was helping them with their stresses. They liked that. And so then it was a much more successful program that I want to now expand and give it to more people.
And people could contact you through your website?
Yes. I do have an email if they want to do that. It's lessstressdoc@gmail.com. Because one of the things that I found, I don't know if you've written a book, but when you write a book, you have to write it kind of generically because I don't know who's reading the book, right? So what I have to do then is write generically. And what people have are very specific problems. So if they have a specific problem, then just email me at lessstressdoc@gmail.com and I can help them out with some specific issues.
Thank you so much, Dr. Gary Sprouse. I feel like I'm in my happy place right now.
Good. Yay.
Bye-bye.
All right. See you later.